Good afternoon. On behalf of Pelham Medical Center and Spartanburg Healthcare System, I welcome everyone and thank you for joining us today. I'm Lindsay Lewis, the Interim Manager of Community Outreach. Today we have a special presentation on the topic of stroke with a panel of 3 different types of therapists here at Pelham Medical Center: a physical therapist, an occupational therapist, and a speech-language pathologist, who I will introduce momentarily. If you have any questions in the upcoming presentation, please type them in the Q&A box and I will ask them to these presenters at the end of the presentation. Today's presentation is titled Overcoming Stroke: Before, During, and After. Our first presenter today is Richard Mello, who is an acute care physical therapist. Richard graduated from Long Beach State in 1999 with a Bachelor of Science degree in physical therapy. He is a certified stroke rehabilitation specialist and currently has worked 7 years for SRHS and 6 years at Pelham Medical Center. Richard is also a clinical instructor for Doctor of Physical Therapy, programs with Anderson University and University of South Carolina students. Welcome, Richard. I will now turn the presentation over to you.
Thank you, Lindsay. So, welcome today. As we go through this stroke presentation, we'll be covering some main topics: general stroke information, which is primarily through me, signs and symptoms, typical hospital procedures for stroke workups, and then rehab's role for evaluation to discharge planning. Some stroke facts. In the United States, strokes are the leading cause of death in America. In the US, someone has a stroke every 40 seconds, and there's a stroke-related death every 4 seconds. I actually think that was supposed to be 4 minutes. In 2009, 34% of stroke-related hospitalizations were people under the age of 65 years of age. 1 in 6 cardiovascular deaths are due to stroke, and African Americans are twice as likely to have stroke risk versus their Caucasian counterparts. For the state of South Carolina, we rank 5th. It's our 5th leading cause of death, and we rank 6th according to states. So that would mean that there are only 5 states above us that rank worse with stroke death rates. And we're about average at a 52% higher death rate for African Americans from stroke versus Caucasians. So we're going to go over what is a stroke. A basic stroke is a damage to brain tissue from interruption of blood supply. There's a couple different ways that can occur. We're going to focus on 3 different types primarily today: transitional ischemic attacks, or TIAs, ischemic strokes, or hemorrhagic strokes. So most of you, when you hear of a TIA, your grandmother, your aunt, or sister will usually say, "I've had many strokes." And that's just another way of people stating TIA or transient ischemic attack. They are temporary blockages that normally last less than 5 minutes, which means that most of the symptoms start to resolve pretty quickly, even though they come on pretty sudden. People that have a mini stroke or a TIA are 10 times more likely than someone who has not had one at the same age and sex. So a treatment for mini strokes or TIAs is understanding your risk factors, which I'll go over later. But you should definitely consider this a warning sign. It's your body stating that something is not going quite right. So ischemic attacks are kind of the same as a TIA, only they last longer and usually more permanent in nature, at least from the onset. So it's a loss of blood to areas of the brain or spine by blockage or clot. This can happen from either different cardiovascular events like AFib. If someone has atrial fibrillation, they can end up with clots in their heart that break off into the brain. They can have deep venous thrombosis or clot in their leg. They can have abnormalities that kind of shunt things off. Sometimes there can be different things that the body does. It just keeps blood from getting to that area. This happens 87% of the cases, 80 to 87% of the cases. And here at Pelham Medical Center, we see mostly ischemic strokes. You can treat ischemic strokes or symptoms with TPA, tissue plasmogenic activator, which is just a clot busting chemical or medication. If you meet the criteria, which a neurologist goes over, and you're here within 4 to 4.5 hours of the symptoms coming on. So unlike an ischemic stroke, so if you're looking at a straw and you were having a smoothie, and sometimes you get a little bit of strawberry stuck in your straw, that's the same kind of thing. The clot gets there and it sticks and you don't get anything else through that point. When you have a hemorrhagic stroke, it is something is causing the blood to leak out. So the blood's no longer going where it's supposed to be going, and it's going to an area where it's not necessarily supposed to go. Well, if you have blood leaking out for whatever reason, it creates pressure, and your skull is there to protect your brain from injury, but it also becomes a hard vessel or like a jar. So if you increase the pressure inside the head by this leaking blood, it puts pressure which doesn't allow normal blood flow to get to that area, but also applies pressure that can kill the tissue around it. So what makes a hemorrhagic stroke more dangerous is that you don't know exactly how much is going to be affected. An ischemic stroke only affects the part that the blood's not getting to. The damage can be much more severe and can be addressed by medication or surgery, which again, the physician would assess upon assessment. So some of the risk factors for strokes. You have modifiable and non-modifiable. So modifiable ones are things that you can take control of and you can adjust over time. Non-modifiable ones are things that you're kind of born with. So for example, you can't change your age. The older you get, the higher your risk is to have a stroke. Family history. If you have family members that have had, if you have 2 or 3 close relatives that have had a stroke, that increases your chances of developing one in your lifetime. Your race, just like I said before, African Americans tend to have a higher prevalence than Caucasians. Gender, men have an incident rate of 33% and a prevalence rate of 41% over females. So what that means is if you take an 80-year-old, 33% of men at 80 will have a stroke more than a woman would, but 41% are more likely to have a stroke at 80 than their female counterpart. And then if you've had a prior stroke or heart attack or TIA, like I said before, that puts you at more of a risk. Now your modifiable risk factors are things that you can change. High blood pressure. You can go to your doctor and you can get medication to assist you with that. Smoking. The sooner you stop, the better. When you stop smoking, within 8 hours of stopping, your oxygen levels return to normal and your CO2 and nicotine levels are halved. Now, I used to work in a cardiac care unit, and our cardiac physicians used to tell patients that you're only physically addicted to smoking for 48 hours and you're psychologically or habitually addicted for 40 days. So once you're hospitalized, normally you stay in the hospital more than 2 days. So it'd be a great time for you to try to stop smoking since you're already past the hardest part of it. Diabetes, keeping your diets and your blood sugars under control. Diet, eating healthier, staying away from processed foods, high fat content. Poor activity level, increasing your activity. High cholesterol, again, taking medication, eating better. And kind of all of these can lead up to obesity, overweight, or can be a side effect of being obese or overweight. And then heart disease. Now, just because a lot of these interact with each other doesn't mean that they all are caused by one. I have known very thin, fit people that have had high cholesterol and high blood pressure. And I've known people that are overweight that have had low cholesterol. But again, if you have any of these things, you should definitely address them with your physician so that they can improve your chances of a healthier lifestyle. And so now I'm going to switch it over to Dina, and Dina will go over symptoms and hospital evaluation.
Thanks so much, Richard. That was super informative. Our next presenter today is Dina Reiner, a speech-language pathologist. She is originally from Pennsylvania and graduated with a master's degree in speech-language pathology. She has been practicing speech-language pathology for 7 years total, 6 years with stroke patients in an acute care setting, and 3.5 years at Pella Medical Center. We're so excited to have you today, Dina. I will now turn the presentation over to you.
All right, hi. I'm going to be talking to you today about the symptoms and hospital evaluations when you have any indications of possible stroke right before you come into the hospital. So the very first thing that we always like to tell the general public for them to know is this acronym we call BFAST. So it's basically an easy way for us to remember the symptoms that normally present when you may be having a stroke. It's important to also note that just because you're having these symptoms does not always mean that you are having a stroke. However, because of the high correlation between these symptoms and strokes, it's best that you just get them evaluated when you have them. So the acronym stands for balance for B. So they loss of balance or dizziness. Your eyes, do you have a blurry vision, loss of vision, or even like difficulty reading things? The facial droop, you'll notice that if you see in the mirror or somebody's looking at you, if one side of your face looks just droopier than the other side, it may be just your cheek or your mouth, or it may even include your whole eyelid, but usually one side of facial drooping. Arm numbness or weakness, so this will be either usually one-sided again, same with the legs as well, but you might notice some numbness or weakness that is concerning for you. Slurred speech, that's usually a pretty obvious one that other people might notice right away, is your speech sounds incoherent, you can't get your words out, something just doesn't sound right. And then the time, it stands for how quickly you get help, because the faster you actually seek out medical attention, the better the outcomes usually are. So this is just a little graph or a chart here that shows what to assess when you start to notice these issues. So it's always helpful to have somebody else kind of help you through this if you start to notice it, but you can still even look in the mirror and do some of these things. But for balance, if you do have a sudden loss of balance or dizziness, you can have that person try to touch their nose with their finger, and then see when they're standing up if they are losing their balance. With their eyes, and you mentioned that, but are they having difficulty focusing? Can they follow your finger as you're moving across their face? And then if they are unresponsive, if you look at their eyes, are they deviated in any way? Are their pupils even? With your face, you can ask the person to smile and show their teeth, so that way you can kind of see if one side of the mouth is drooping a little bit more. If you ask them to smile, one side might not pull back quite as far as the other side, so it would be a little bit obvious. Or if you're just looking and their one eye looks a little droopy as well. With the arms, you can have them hold up both their arms and see if they can hold them straight and even for about 10 seconds. If you start to notice that one arm is drifting down a little bit, then that's another sign. And then your speech, like I mentioned, it might sound a little slurred, so you can ask them to say a phrase. For example, here we say you can't teach an old dog new tricks, but if you can't remember that, just have them say something in general to assess how their speech sounds at that time. And then with the time, again, just notify someone as quickly as possible. And if you need to seek medical attention, then the best recommendation is to call 911. So it says when to go to the hospital. If you're experiencing any of these symptoms, it's best just to seek out medical attention right away. Typically, we would say call 911 because the paramedics would actually be able to more quickly treat your symptoms if it's very emergent versus waiting for the whole drive to the hospital to have it assessed. However, if you can get here quickly, just in general, get yourself to an emergency room. And then why go to the hospital? So as Richard actually mentioned earlier, that it's very important that any of these signs and symptoms get addressed as quickly as possible, because the outcomes and your recovery are better chances if you do have them evaluated and treated in a more timely manner. So a neurologist will come in, or either a neurologist in person, or via our teleneurology, they will determine whether you may be a candidate for TPA, as Richard explained earlier. So that's a drug that can be administered if you have an ischemic stroke. It can be given to break down the clot and hopefully get blood flowing again, and then hopefully reduce the amount of tissue damage in the brain. So again, that was a timed thing. So they don't usually administer it if the symptoms presented more than 4.5 hours ago. So that's another reason why you want to get in quickly, because if it's within that window, they can administer it. If you get here sometimes 6, 7, or even the next day, hours during the next day, which a lot of people do tend to do because they downplay their symptoms, they'll give it time, then you might fall outside of that window and you won't get to have the drug administered. If they see a hemorrhagic stroke, it's also very important because like Richard said, it's very detrimental with the hemorrhagic stroke, where you may need emergent surgery to stop the bleed, or if they need to figure out in general what they need to do to stop the bleed or prevent any further bleeding. So the longer you go untreated, the higher the risk of long-term damages. What to expect when you get to the hospital. So as soon as you get here and you explain your symptoms, they're most likely going to start a stroke workup. You're going to immediately be brought down for a CT of the head to see if there is any immediate bleed. So that would be the very first thing they do, because that is the one that they would want to address the quickest. And then while they're actually in the process of doing that, you will have your blood drawn. Once you have that completed, we will consult teleneurology, and they would make the decisions if you need to be admitted, or if maybe you would benefit from the TPA administration, and then the general plan for your workup. Then once you are admitted, they will start doing multiple tests. You'll have an MRI, an echo, carotid Dopplers, and any other testing that the physicians see fit for what you're presenting with, as far as starting you on other medications related to stroke. And then we, as the therapists, come in, you'll get all of us. We have physical, occupational, and speech therapy. We all address different things. So if you do come in with a stroke workup, even if you don't have any areas of deficits that seem to correlate with our therapy, we still come in and assess, just because strokes can really be hit or miss with anything, and we don't want to overlook anything. So you get all three of us every time you come. And that is it for me. I'm going to turn things back over to Lindsay.
Our last presenter today is Katie Atkins, who is an occupational therapist. She is originally from Louisiana and graduated in 2014 with a master's in occupational therapy from the University of South Alabama. Katie has been an occupational therapist for 6 years and has worked for Pella Medical Center for 2 years. She is also a certified stroke rehabilitation specialist. Welcome, Katie. I'll now turn the presentation over to you.
Thank you, Lindsay. So yes, as Lindsay said, I'm going to cover the role of rehab when working with strokes. And typically, like Dina said, we come in to work with you, physical, occupational, and speech therapy, once you're medically stable. So you'll have the tests, some of the tests done first, and then the therapist will come in to assess you. And like she said, you will have all three disciplines, even if you do not have symptoms related to that specific one. So you can expect to see all three of us if you come to Pelham Medical Center. And just to mention, the initial goals of therapy and rehab are usually for restoration. So we're working on restoring the function. So if it's a loss of strength, we will focus on regaining the strength. And then later goals usually address compensation. So we're learning to modify, adapt, adjust, kind of changing how you do things if let's say your strength doesn't come back as it was before. So the first therapy we'll talk about is physical therapy, which usually addresses gross motor movements. So that's your big muscle groups. So typically you think of the legs for physical therapy, and they address a person's ability to move around in their environment. And as you can see, they're working on steps there. So for a physical therapy assessment, and actually for all three disciplines, for physical, occupational, and speech therapy, the evaluation typically begins with an interview, and that can be performed with just the person that has come in for the stroke workup or with the family present as well. And we just really want to know kind of what you were doing prior to the symptoms, who you live with, who's available to help you at home, your living arrangements, equipment, just all of that information. And from there, after the initial assessment, physical therapy will look at all of these things. They focus on a lot of neuromuscular symptoms, so sensation, if they have muscle tone, different reflexes. They'll also look at musculoskeletal, so the strength. They'll look at some posture, like sitting up and standing as well, and just general range of motion. They do skin assessments, vision, balance in sitting and standing, and coordination. And then they'll look at all of the mobility options. You have in and out of bed, bed mobility, transfers, the walking, and if they need to look at stairs, that is something they will look at as well. And then occupational therapy, which is what I am, addresses activities of daily living, or we consider that the meaningful activities that people do every day. I'm not finding you a job. That is a typical question that I have. We consider an occupation something that you do every day. And so in the acute care setting, in the hospital, that is going to the bathroom, getting dressed, bathing, grooming, feeding yourself, anything you do on a daily basis. And then for the occupational therapy assessment, it is similar to the physical therapy assessment. We look at some of the same things. We look at the neuromuscular stuff like sensation, muscle tone, the musculoskeletal, range of motion, posture, and muscle strength. Typically, physical therapy will focus more on the legs, whereas occupational therapy will focus on the arms. However, there is some overlap because sometimes you have to look at everything to make sure it's safe for someone to get moving and get out of bed. Occupational therapy also looks at vision, balance, and coordination. And then with OT, we really look at cognition. So ability to follow commands, safety awareness, going through and being able to start a task from beginning to end and complete it at the end. We also look at functional mobility, so those transfers and getting up and moving, but it's specific to an activity of daily living. And then we will also look at the activities of daily living, so the bathing, dressing, going to the bathroom. So the best way to explain the treatment in acute care is kind of going over physical and occupational therapy as a comparison because they do overlap some. And so a good example is with walking. For physical therapy, they really work on the longer distances. So they're working on walking around the house. So you're walking in the hallway, longer distances, going up and down the steps. Whereas occupational therapy may also address walking, but we're working on something specific to the activity. So walking to the sink to brush your teeth, or walking to the bathroom and working on getting on and off the toilet. So there is some overlap, but they do have specific goals and purposes behind it, even if they seem to be working kind of on the same thing. So with physical therapy, they look at bed mobility. That is getting in and out of bed, scooting up in the bed, rolling, just any kind of activity that you need when you're in the bed. For transfers, they'll work on transfers, that is going from sitting to standing. Sometimes a person may not be able to walk, so we would focus on going from maybe just the bed to the chair or a chair to a wheelchair. And then if they're able to stand up and they can take some steps, they'll look at the walking, and then they will also address steps and stair climbing if needed. And then for posture, typically, when you're working, especially with the initial evaluation and then working on treatment, you always address sitting first because you're not really going to be able to have someone stand up or walk if they're not really able to safely sit. So they will definitely look on posture, trying to find, helping patients to find their midline, so finding the center. People with stroke tend to lean to one side. They may not be aware of one side of their body, so they'll kind of have a hard time getting in the middle when they're sitting and standing. And then they will also work on balance, and that can be sitting balance, standing balance. It can be static when you're not moving, just sitting or standing. And then dynamic is moving while you're sitting or standing, reaching, kind of stepping outside of your base of support, so stepping outside of where your balance is. They can also work on leg function, which would just be the coordination, strengthening, making sure that they're controlling movements, any type of sensation. They will also work on that. And then with vision, they focus a lot on looking through the environment to see if there's obstacles, making sure that when they're up and walking, they're not going to run into the bed or the door. the table that's there. So just really working on kind of scanning in the environment. Physical therapy also works on wheelchair mobility. It's not something very common at Pelham Medical Center when you're in the hospital setting. If someone used a wheelchair before, that is definitely something physical therapy will address. But typically, if you're coming in and you might need some therapy when you leave the hospital, if you're going to a rehab facility, they'll focus more on the wheelchair mobility there. And then family and caregiver and patient training. That is a huge thing that all the disciplines work on, all therapists work on, just kind of emphasizing the type of help someone may need at home if they're going home. So that could be help cognitively, just kind of safety awareness or cues. It can also be physical help, kind of where to have your hands if someone needs hands-on help to get up and move around. Physical therapy also works on, if they need a cane or a walker, they can kind of guide you in the right direction of which one's going to be safest. Just general safety for home, and also symptom management. So sometimes after a stroke, someone may get dizzy when they stand up. Just kind of learning how to keep yourself safe and not have falls whenever you're back home. And then for occupational therapy, a few similar things. Occupational therapy does work on the basic ADL performance and safety. So typically with OT, we'll work on balance, but it's specific to standing up and working on pulling your clothes up while you're going to the bathroom or getting dressed. So we'll really tie that functional task back to the underlying deficit. And then for a mobility and transfers, like I had said earlier, it's always with a purpose to do an ADL, get to the sink to brush your teeth. In and out of bed, or rolling in the bed because you're not able to safely stand or sit yet to do like a bath in the bed, if that's kind of what they need to work on. And then, like I said earlier too, occupational therapists typically work on the arms, the shoulder, arm, and hand function. That's strengthening, coordination, dexterity, any sensation deficits that someone may have. Upper extremities, when you have a stroke and if it's severe enough, sometimes the leg muscles will actually come back and get stronger before the arm muscles. Typically, the bigger muscle groups in your legs will actually recover faster. So you might have, they're moving around better, they're walking, but the arm may not be working as well. So occupational therapists typically work on positioning with the arm, making sure it's not getting left behind. Sometimes people will let it kind of drag in a chair, and you just run the risk of getting a subluxation, which is when your shoulder muscles, they can get paralyzed or they're very weak, and they don't let the humerus bone, which is your upper arm bone, it'll actually hang down, and it can be very painful. It can be hard to kind of treat once it happens, so we work a lot on prevention if the arm isn't functioning very well, so making sure that arm is supported in the bed, in a chair, in a wheelchair. Even when up and moving, we want to make sure that arm's supported. So occupational therapy will typically focus on the positioning. And then visual function, OT works a lot on finding the objects you need in the environment. So if you're standing at the sink brushing your teeth, they'll work on trying to find those, the toothbrush and the toothpaste when there's other things on the counter, or just making sure that people are looking to that side to find things. And then they'll also work on navigating obstacles and kind of making sure that, everything in the environment is really safe. And then cognitive function, like I had said, is really addressing that safety awareness and kind of initiating a task, so starting the task and then being able to go through all of the steps to complete it. And then also following commands. We'll start with a simple one step and we can progress from there to get a little bit more complex for the commands. And then again, family, caregiver, and patient training is super important. We'll kind of talk about the assist level for the ADLs and for the mobility and maybe safely getting in and out of the shower. And there again, it can be cognitive. So just maybe those cueing assist levels, or actual physical hands-on help, like helping someone put on their socks. We also work on equipment recommendations, really kind of going toward more of the bathroom recommendations. That's typically something I focus on. Home safety and just kind of home and task modifications, just keeping the environment very safe and just setting it up for success and minimizing fall risk and really minimizing injury for whoever is going to be helping the person as well as the person who has had the stroke. Okay, so now I'm going to turn it back over to Dina. She's actually going to go over the speech therapy's role during the hospitalization.
So speech therapy, we address in many different areas as well. So when a person comes in with any concern of a stroke, the very first thing that becomes the greatest safety concern is their swallowing. So any deficits of swallowing is considered dysphagia. That can start as early as the reception of what you're eating. So being able to like take the food from the spoon or from your hand. And then it becomes the chewing and then the physical swallowing component. And with strokes, this is one of the main things that is affected in my area. And we have a concern for safety because it can become a risk of aspiration, meaning food or liquids getting into your lungs while you're eating and drinking, or just straight choking, meaning the actual blockage of your airway from food getting in there. And because that's such a high risk, we take really major precautions when a person comes in. So as soon as you come in, the nurse will actually do a quick screen just to make sure overtly that you will be tolerating at least to start a diet. But then speech therapy always comes in and does a dysphagia evaluation just to make sure there's nothing wrong. And if there is, there are ways that we can address that. I may need to do further instrumentation or evaluation, meaning a X-ray swallow study to see how everything is going down a little bit more directly, or I can do a FEES, which is a fiber optic endoscopic evaluation of swallow, and that is a scope that we place through your nose into the back of your throat where we can see visually down into your throat while you swallow just to see how everything is going. And depending on the results of those studies, we can determine what type of diet that you need to be on, and if you need any sort of compensatory strategies, we call them, meaning like a different way maybe to eat and drink that might reduce that risk, and any exercises that we need to start that can help to improve your swallow altogether. The next most common thing that we treat would be our aphasia. So this is a language impairment. And this is one of the main things that people might actually notice as one of the first symptoms related to speech. So they might actually have difficulty in the receptive area. They might have difficulty understanding other people. So they might actually not be able to comprehend what other people are saying, or even themselves, depending on the severity. So they might be saying stuff that doesn't make sense and they're not even aware that they're not making sense because they're not understanding that they're saying it wrong. Then there's expressive aphasia, which is basically our ability to communicate and express ourselves. So this might sound impaired because they have difficulty finding the words they want to say, or maybe the words that they're saying just aren't coming out right. Patients usually are aware when they have these issues, and they get very frustrated too because they know what they want to say, but it's just not coming out right. So we evaluate for that, and sometimes it's just a screen depending on what the presenting symptoms were. But if we find any need to do further evaluation, we will, and then again create some goals and exercises that can improve that. Then there's dysarthria, which is a motor speech impairment. So this is where your speech is actually starting to sound just imprecise, like your articulation is decreased because you have muscle weakness to your face, your lips, your tongue, your jaw. And so you say the words you want to say, they just don't sound right because they're just not as precise as normal. This can often be confused with apraxia of speech, which can also occur with strokes, where apraxia of speech is actually a motor planning deficit. So it might sound like a person is trying to say a word, but they keep trying and trying and the word just isn't coming out right. It might kind of sound like the word, but the certain movements with their mouth they're making isn't right because the brain is having a hard time sending the right signal down to the muscles to make what the sound they actually need to make. And then with cognition, we do overlap with OT with cognition, except ours is just a little bit broader. We don't really focus it onto any one specific activity or behavior. We try to generalize it to everything. So we work on thought organization, reasoning, safety, and orientation. And we try not to overlap OT as far as if they are working on certain things that are directly related to your activities of daily living, we will try to adjust other things because we don't want to overlap and basically having you get treated the same thing double time. So we will address those, and typically that takes a little bit more time than acute care. So in speech therapy, we might start to address it in the hospital if you're here for a little bit longer, but that's more of something that would be addressed when you go to either home and get home health services or rehabilitation center, or if you end up going to like a skilled nursing facility, they'll really dive in a little bit deeper to see more in depth what you need and work on it there. I think that's it for speech, so I'll turn it back over to Katie.
Okay, so now I'm going to discuss discharge planning. And I just want to make sure everyone understands that when you come in and that you have your occupational, physical, and speech therapy evaluations, you may actually have no needs, and you may not need therapy while you're in the hospital. You may only need 1 or 2 of the therapies and not need 1 or 2 of the others. So it just kind of depends on your symptoms and how you're presenting, and things change when you have a stroke, and you might be good when you first come in, and things might get a little bit different, better or worse the next day. So we just be aware you may not have all 3 of the disciplines, but after initial evaluations are completed, the rehab staff makes recommendations for if you need therapy during your hospital admission and then for the next level of care. So kind of going where you're going to go whenever you leave the hospital. And sometimes, even if you have therapy at the hospital, you may not need therapy when you leave, so you might not have any needs at discharge. But recommendations may also include outpatient therapy, and this is typically you're going to a physical building, so it's usually for someone that's higher level and is able to get in and out of their house, in and out of a car easily, and doesn't have any transportation issues. You are not supposed to drive yourself after a stroke, so you will need someone to help you get to your outpatient therapy if that's where you end up going. And then home health therapy is someone who's considered basically homebound, or it's a very difficult task for you to leave the home. That could be getting in and out of your house because there's steps, or in and out of a car is very difficult, or it's a really big task and you don't have transportation, or it's not safe for you to be transported somewhere. And home health really addresses concerns related to safety in the home. So, getting in and out of your bed, getting in and out or on and off the steps, or in and out of your house, or if you have a bedroom on the 2nd floor. They'll focus on just modifying the environment for safety, any home safety, bathroom safety, carryover with any family or friends that are assisting at home. So it really focuses on safety and function in the home. And then there's also skilled nursing rehab, or sometimes you'll hear it referred to as SNF rehab. It's SNF rehab. And this is typically for people who are having needs, but they can't tolerate a very aggressive therapy. So usually the therapy that you have is a little bit less per session and per day. So it's not going to be the 3 hours, and I'll talk about inpatient rehab after, but it's less intense daily, but usually for a little bit of a longer duration. So if you're just needing a little bit less aggressive therapy, but you might take a longer time to recover, this is a good option. And you may not have physical, occupational, and speech therapy if you have to go to skilled nursing rehab. It could just be physical and occupational therapy. You may not need the speech. Sometimes it's just occupational and speech. Sometimes it's just PT and speech. Typically, though, if you're going to skilled nursing rehab, you're getting at least occupational and physical therapy, and then the speech can be just determined there as well. And then acute inpatient rehab is very intensive and aggressive for a total of 3 hours per day, and it's typically a shorter duration than the skilled nursing rehab. You don't necessarily you're not going to have, 3 hours of physical therapy. It will be divided up across physical, occupational, and speech therapy if you need it. And so they will determine that whenever you get there as well. So we just like to encourage everyone that, and as Richard said, you got to start thinking wellness and not illness. There are a lot of things that you can modify before you've had a stroke. And once you've had a stroke, there are things that you can modify as well. And then we know that having a stroke can be very stressful, and it's definitely a life-changing event. And it's not just for the person who's had the stroke, but it's also for the family and friends that are involved as well. And we have found over time that a good support system and having a really positive attitude has really been shown to improve your quality of life and really just your overall outcomes from therapy and going to rehab or having therapy at home. It just really improves it overall. But we do understand that sometimes it can be difficult to see the light at the end of the tunnel. It can be, like I said, it's a very stressful and life-changing event, but you just have to remember there is life after stroke. So just try to keep a positive attitude. And these are our resources and references. If you have any questions or you want to just refer to something later on, these are the references that we used. And that is all that we have for our presentation. So I'm going to turn it back to Lindsay to see if we have any questions.
Thank you so much, Richard and Dina and Katie, for all of your different portions of your presentation. I know I learned a lot, so I hope all of you out there have learned just as much. I can't thank you enough for taking the time to be with us today. We do have several questions, so I'll try to get through as many as I can. I just wanted to reiterate the importance of this education to prevent a stroke, because obviously that's the importance of this. Prevention is key. So I just thank you three for coming, and I hope everybody has learned a lot. Alrighty, so let's look at our questions. Our first question today, I think I will try to gear towards Richard. It looks like somebody has asked that, or somebody has stated that they have frequent and consistent headaches. Is that a warning sign of TIA, Richard, that you talked about earlier?
That's definitely a reason to go see your physician. There's lots of things that can cause a headache. We get patients that come in with headaches that sometimes can be a precursor, can be a symptom. Sometimes it's something else causing it, but that's a physician question. So I would definitely start there, and they'll refer you to a specialist from there.
Okay, thank you. Another question for you, Richard. It looks like somebody has asked about at-home exercises in physical therapy. So I guess once you've had a stroke, are there any exercises they could do at home once they're released from the hospital?
That's a hard question because it depends on what your limitations are. So like Katie had said, you would be assessed at the hospital. We would give you a certain set of exercises when you leave the hospital. Then if you were to go home or if you were to go to rehab, they would give you another set because you'd be a little different level. And then when you went to outpatient, they'd give you another set. So we might give you exercises that work on gross function or just basic moving of the legs up and down, sliding side to side, getting your hand from the table to your shoulder, things that help with transitions out of bed, things that help you feeding, stuff like that. And then when you were to go to the next level, they would work on standing exercises for balance and things like that. And an outpatient would work on even higher to get to fine-tune your walking and fine-tune your ability to stand. So you will get multiple exercises from multiple people throughout the course, and they will give it to you accordingly.
Okay, wonderful. Thank you. It looks like our next question is geared towards Dina. It says, what is the biggest challenge for your patients who have come to you in speech language pathology who have had a stroke?
I think the biggest challenge is with individuals with the communication issues. That really affects their quality of living. I mean, really all areas that they have deficits in, it affects their quality of living. But I see the most emotional responses when patients are not able to communicate, especially if they can't even express their wants and needs, and they're aware of their errors and their difficulty. And you usually try to go in there and just try to get them at least to the point where we can somehow, some modality, get them to express themselves, even if it's not just straight words or verbal. And that might take some trial and error and just practicing. But I do think that's the biggest challenge for my patients specifically.
Thank you so much for that. Katie, it looks like our next question says, if I'm a caregiver of a person who has had a stroke, what would you say is the best way I can support my loved one?
Well, the best way is really to have a good attitude, and honestly, that in just from a physical and giving help as needed, that's going to depend really on what kind of deficits we see, if it's strength, if they're needing help with safety awareness, if it's hands-on help, or just kind of making sure someone isn't, turning on the stove and leaving it on. Just, it's going to really depend on what we see in the hospital setting, but then even at home, you can progress and things will change over time. So it's good to really talk with the therapist that you have in acute care. If you need rehab, skilled nursing rehab, or inpatient rehab, and then home health, they can definitely do a lot of education and training to point you in the right direction of how you can help and support, but really just providing like a positive attitude and really being encouraging. It's really easy to get discouraged when you have a stroke, especially if you're aware of the deficits that you have. So people will tend to harp on that. Depression is definitely something that is very common with patients who have had strokes. So just trying to be really encouraging and really just have like the best attitude that you can. And it's also important, if you're a caregiver, to take time for yourself. Something we stress is caregiver burden and caregiver burnout. When you are having to help someone, even if it's not providing a lot of physical help or a lot of just help in general, you have to take time for yourself as a caregiver to go see a movie or just take some time away and kind of have that outlet, so that you don't get overwhelmed as well, because it can be difficult to help someone just over time.
Trying to find a support group for yourself. Trying to find family members to take over once a week. And also learning how to respond, because we all have different response levels that we interact with family members versus regular people. When we interact with your loved ones, we don't know them from anyone else, so we treat them with the love and compassion of a therapist treating a patient. When you interact with them, you're interacting with them as a daughter or a husband or a wife, and you have everything that came up to that point, and you have to learn sometimes to change the way you interact, which is very hard.
Wonderful. Thank you so much for both of y'all's inputs on that. One more question before I get to the last question is also for Katie. It says, what have you found is the most common or the most challenging daily living activity those who have had strokes have to relearn?
There again, it does really depend on what deficits we see. I typically tell all of my patients the hardest thing that you're going to do when you go home, typically number one is getting in and out of bed, but really taking a shower is probably one of the hardest things to relearn. There's a lot of safety concerns involved with anything in the bathroom, even just going to the bathroom and getting on and off of the toilet. But showering is probably the biggest thing. It really depends on the setup you have. If you have a walk-in shower versus a tub, having to step in and out. Do you have help? Are there bars on the wall? Do you need a seat to sit on? Those kind of things. And then just from a safety aspect, it's wet when you shower. It really does increase your risk of falls. Are you able to fit your walker if you need one in the bathroom? So I think showering would probably be the hardest thing, just because it is a very complex task. There's a lot of safety concerns overall. Typically, we do see a lot of people falling in the bathroom. Although sometimes I tell people that people expect to fall in the bathroom, so they're actually a little bit safer in the bathroom and then not safe, in the kitchen or somewhere else. But that generally is probably the hardest thing that I would say.
Great, thank you. The last question I have is going to be addressed to each of you, so we can start with Richard and just go down the line. It is, if you had one tip to help those not have a stroke or not have a second stroke, what would it be? Richard, you go ahead.
I would say open communication with your doctor. Don't be afraid of your physician. They're there to help you. I'm relatively young, but I've been on blood pressure medicine for a long time, and it took a lot for me to finally admit and go to my doctor 4 months later and say, you know what, I think we need to change my medicine because my blood pressure is still a little higher than we want. Because I saw a sign the other day that said blood pressure is the secret killer, because you can have blood pressure that's high. I put on my sheet the new national normal for blood pressure is 120 over 80 or less. It used to be 140 over 80. So if you're at 130 over 80 to 90, you're considered high blood pressure. And you don't feel it, your arm doesn't go numb, you don't always have headaches, you don't have anything that lets you know that. But if you stay in those high numbers consistently and prolonged, it puts stress on your blood vessels, it puts stress on your heart, and that is probably the best thing you can do for yourself.
And then I think mine would just be like, kind of like Richard said, you really need to be honest with your doctor, but you really need to be honest with your family. If you're not feeling well and you're just kind of hiding things for a day or two, a week, and your family isn't really noticing, that is concerning. And it's also just making sure that you are like listening to, you know, your doctors, your therapists, your family. They really want what's best for you. So you just make sure that, you know, if you have a recommendation from a doctor or therapist to try and avoid something, it really is something that you should take to heart. It can be difficult. I know, you know, stopping smoking or changing your diet, but any of those things can be very difficult, but just really listen to kind of the advice and the recommendations that are out there.
And I feel like there's an important factor in listening to your own body as well. So know like your body's homeostasis and monitor for any changes that maybe you haven't noticed in the past. And even if it's small and insignificant, like Richard said, just the more if you bring it to the attention of your physician, like it may be a warning sign. So pay close attention to your body, and you know your body better than anyone else. So if you start to notice changes, not even just stroke symptoms, but just changes in general about how your body operates or how you're feeling, just bring all those any changes up to your doctor so that if it is maybe a warning sign or a risk factor, then you can address it early.
All righty. Well, thank you guys so much. I just wanted to say again, thank you to Richard, Katie, and Dina for taking the time to give us this informal presentation. Please be on the lookout for our next virtual presentation that will be in July. I hope everyone has a great day.